Hello and welcome back to the Deep Dive. Today we're doing something a little different, something I know a lot of you have been asking for. We are going to abandon the usual format and step directly into the shoes of a very stressed out postgraduate student.
I think stressed out is probably an understatement.
Yeah. Specifically, we're role-playing an MD anesthesiology resident, and the Gujarat University exams are looming.
Which means rigor. It means we need structure, we need precise definitions, and, we absolutely have to survive the viva voce.
Exactly. And the topic today is, frankly, a monster. We're tackling weaning from mechanical ventilation and extubation. Looking at the sources here, Harrison's, Miller, Kilnani's ICU protocols, and it just feels like a complete minefield. There are all these indices, acronyms, flowcharts, numbers that seem to conflict. I mean, if I'm a student walking into that exam hall, my biggest fear is that I'm going to mix up weaning with extubation and just fail on the spot.
And that fear is entirely justified. That is precisely where students lose marks. So for this deep dive, let's get into character. I'll put on my senior faculty hat.
Okay.
I'm that professor who, wants you to pass, but I am not going to let you get away with sloppy definitions or lazy thinking.
I'm ready. Sean the student, pen in hand, probably sweating a bit, and I need to structure the perfect 20-mark theory answer. So where do we even start?
We start with the mission statement. Look, in an exam, precision is your shield. The very first thing you have to establish before you even mention a ventilator setting or a drug is that weaning and extubation are not synonyms.
Okay, so that's the first trap. Because we use them interchangeably all the time in the ICU, don't we? You say, let's wean them off, when what we really mean is, let's take the tube out.
It's a terrible habit. It's a bad habit that will get you failed in a viva. So let's define it. Weaning, or the better term really, is liberation, is a process. It's the journey.
Our process.
Yes. It's the gradual reduction of ventilator support, transferring the work of breathing from that machine back to the patient's own muscles. It's not a single moment. It's a phase that can take up, 40 to 50% of the total time a patient is on a ventilator?
20 to 50%. Wow.
Yeah.
Okay, so if weaning is the process, extubation is?
Extubation is an event. It's the anatomical removal of the endotracheal tube. Simple as that.
Right.
And here is the absolutely crucial distinction for your answer. A patient can be successfully weaned, meaning their lungs are working, their gas exchange is perfect on their own, but they might not be ready for extubation.
Because they can't protect their airway?
Precisely. So if you tell an examiner, the blood gas is perfect, so I'll pull the tube, but the patient has, say, a GCS of 7.
I fail.
You fail immediately. You've just described creating an unsafe airway. That single distinction is the foundation of your entire answer. You must write this in your introduction. Weaning is the restoration of physiological breathing. Extubation is the restoration of the anatomical airway.
Okay, that's crystal clear. Foundation laid. Weaning is the journey. Extubation is the destination. Let's move to the next high-yield section. The physiological basis of weaning. This feels like the part where I could just memorize a list, but I suspect understanding the why is where the real marks are.
Of course it is. If you want the distinction marks, you have to explain the core balance. I want you to imagine a weighing scale in your mind.
Okay.
On the left side, you've got respiratory load. On the right, you have respiratory capacity. Weaning failure isn't some random event. It's basic physics. It happens when the load is heavier than the capacity.
Let's break down that load side then. What are we actually fighting against? What's in that bucket?
You're fighting physics. The load is made of two main things: resistance and elastance.
Okay.
Resistance is anything that makes it hard for air to flow. Think about bronchospasm or thick, tenacious secretions, or even the endotracheal tube itself. Breathing through a thin straw requires work. A smaller tube means higher resistance.
Right, and elastance.
Elastance is stiffness. It's the opposite of compliance. If the patient has pulmonary edema, or ARDS, or fibrosis, their lungs are stiff like an old balloon. It takes a huge amount of energy just to inflate them with each breath. That's a massive load.
So load is resistance and stiffness. Then the capacity bucket must be the patient's ability to overcome that load.
Exactly. And capacity depends on just two things: drive and strength.
Drive and strength.
Drive comes from the central nervous system. Is the brainstem actually sending the signal? Is it yelling breathe properly? An obtunded patient or someone on heavy sedatives has low drive. Their capacity is shot.
And strength is the muscle part.
It's the neuromuscular component. Can the diaphragm and the intercostal muscles actually execute the brain's command? This is where your systemic preparation comes in. If you have a patient with, say, severe hypophosphatemia, their diaphragm is weak. It can't contract properly.
So their capacity plummets, the scale tips, and
Seaming fails. It's inevitable. It's not bad luck. It's predictable physiology.
that's a brilliant mental image for a theory paper. Load versus capacity. So before we even think about touching the ventilator knobs, we have to try and balance that scale.
Which brings us to the absolute first line you will write in your management section. It's so obvious people forget it. Resolution of the primary cause.
Right. You have to fix what broke in the first place.
All the time people miss this. You cannot wean a patient if the reason they were intubated, septic shock, raging pneumonia, acute heart failure, is still active. If the house is on fire, you don't take away the fire hose.
Seems logical.
If they came in with cardiogenic shock and their heart is still failing, weaning is just a futile academic exercise that tortures the patient.
So step 1 in the plan, fix the primary problem. Step 2 would be fix the whole system.
Yes. We call this ensuring systemic readiness, and you tick off the systems. Cardiovascular, is the patient in shock? No. They should be on minimal or ideally 0 vasopressors. Then you look at the metabolic status. Now, this is a classic Viva question. Which electrolytes are you most concerned about before weaning?
And I shouldn't just say all of them. I need to be specific.
You need to be very specific. The big 3 for muscle function are phosphate, magnesium, and potassium.
Okay, why those 3 specifically?
Because they directly fuel the respiratory muscles. Hypophosphatemia and hypomagnesemia cause direct, measurable diaphragmatic weakness. You could have the healthiest lungs in the world, but if the diaphragm is out of fuel, you're going to fail the trial.
And what's the mechanism?
Well, phosphate is a core component of ATP. Adenosine triphosphate, that's cellular energy. No ATP, no muscle contraction, simple as that. And magnesium is crucial for function at the neuromuscular junction and for stabilizing ATP. You need all of them to be in the normal range.
That is a very high yield point. Check the phosphate. Okay, so let's say we've done all that. The pneumonia is clearing up, the pressors are off, the electrolytes are normal. Now we can move on to the wean screen, right? The assessment of readiness.
Correct. And you must present this in your exam as a mandatory daily ritual. Every single patient on a ventilator gets screened every morning. The core question is simple. Is it safe to even try a weaning trial today?
Okay, so break down the criteria for that screen. There are a lot of numbers to remember.
Let's organize it. Start with hemodynamics. You want the patient to be stable. A heart rate less than 140 is a good general guide. More specifically, you don't want their heart rate to swing wildly, say, by more than 20% with minimal activity.
And blood pressure.
Systolic blood pressure, somewhere in the range of 90 to 160 mmHg. And critically, no active myocardial ischemia. If you see ST changes on the monitor or if the patient is complaining of chest pain, you do not add the stress of weaning to that heart. You back off.
Makes sense. What about their mental status?
They need to be arousable. We're not asking them to do a crossword puzzle, but a Glasgow Coma Scale, or GCS, greater than 13 is a good target. The most important thing here is that you have to stop any continuous infusions of heavy sedatives like propofol or midazolam. You cannot assess the readiness of a sleeping patient.
Right. Turn off the sedation.
Right.
Now for the really number-heavy part, the respiratory criteria. I feel this is where students get bogged down because the textbooks all have slightly different values. What's a safe baseline to quote in an exam?
Stick to the standard safety limits. For oxygenation, the best measure is the PO2-FiO2 ratio, the PF ratio. You want that to be greater than 150, ideally over 200.
And PEEP and FiO2.
The PEEP should be low. It signifies that the lungs are staying open on their own, so you want a PEEP of less than or equal to 5 to 8 centimeters of water. And the FiO2, the fraction of inspired oxygen, should be less than or equal to 0.4 to 0.5, so 40 to 50%.
So in simple terms, if they need 70% oxygen just to maintain a decent saturation, they are nowhere near ready.
Exactly. But here's the nuance for Aviva, the thing that makes you sound like you've actually been in an ICU. These numbers are guides, not laws. A patient with chronic COPD might live with a PF ratio of a 180 and be perfectly fine. You always have to consider the patient's baseline.
But for the theory paper, I should stick to those numbers.
For a written answer, you write PP less than 8, FiO2 less than 0.4. Also, check the arterial blood gas for pH. It should be above 7.25. If they're acidotic, their respiratory drive will be through the roof and they'll just tire themselves out in minutes.
Okay, that's clear. Now let's say they pass this screen. They're stable, awake, and their numbers look good. Now we enter the world of predictive indices. This feels like where all the acronyms live.
It is, but this is where you score easy technical marks. Examiners love asking about predictive indices because they represent an attempt to put a number on the future, to predict whether the patient will fly or crash when you reduce support.
Let's start with a simple one. Minute ventilation, or V.
Right. Minute ventilation is simply the total volume of air a person breathes in 1 minute. A normal person, you or I sitting here comfortably, we're moving about 5 to 6 liters of air per minute.
Okay.
Now, if your ventilated patient requires a minute ventilation of, say, 12 or 15 liters per minute just to keep their carbon dioxide level normal, that's a huge red flag.
This means they're working way too hard.
It implies one of two things. Either they have a lot of high dead space wasted ventilation, or they have very high CO2 production, maybe from a fever or sepsis. Either way, it's physically exhausting to move that much air. So a V greater than 10 liters per minute should make you pause.
Okay, that makes sense. What about measuring their muscle strength more directly?
For that, we use the MIP, the maximum inspiratory pressure, sometimes called Pmax. It's a raw measure of diaphragmatic power. You essentially block the airway for a moment and ask the patient to suck in as hard as they can against the obstruction.
So it's like creating a vacuum. We're looking for a big negative number.
Exactly. A more negative number is better. We want the MIP to be more negative than negative 20 to negative 30 centimeters of water. Remember, negative 30 is a much stronger suck than negative 10. If they can only generate negative 10, their muscles are too weak. They won't be able to take a deep breath off the machine.
Okay, MIP for strength. But we can't talk about indices without mentioning the big one, the celebrity of the group, RSBI.
The Rapid Shallow Breathing Index.
Yes.
Developed by Yang and Tobin. If you remember nothing else from this section for your exam, you must remember the RSBI. It will appear in short notes, it will appear in vivas, it will definitely appear in MCQs.
So give us the formula.
It's beautifully simple. The RSBI is the patient's respiratory rate or frequency divided by their tidal volume. The tidal volume has to be measured in liters. So F divided by VT in liters.
And why is that specific ratio so powerful? What's the physiology behind it?
Because it perfectly captures the pattern of impending respiratory failure. When a patient starts to fail weaning, they don't just stop breathing. They adopt a very inefficient breathing pattern. They start taking fast, tiny, shallow breath.
So the numerator, the rate goes way up, and the denominator, the volume, goes way down.
And the index, the RSBI value, skyrockets. It's a mathematical snapshot of failure.
So what's the magic number, the cutoff?
105. An RSBI of less than 105 breaths per minute per liter predicts a high likelihood of weaning success. An RSBI greater than 105 is highly predictive of failure.
How predictive are we talking?
Well, this is the important nuance. An RSBI over 105 is highly specific for failure, maybe 95% specific. If it's high, they're very likely to fail. But an RSBI below 105 is only fairly sensitive for success, maybe around 80%. It's a good screening tool, but it's not a crystal ball.
Is it foolproof?
Absolutely not. And pointing out the limitations is what gets you the distinction grade. First, there's a gray zone between about 80 and 105 where it's a bit of a coin toss. Second, it's not very accurate if the patient has a very small endotracheal tube, say less than a size 7.
Why is that?
Because the resistance of that tiny straw artificially increases the work of breathing and can falsely elevate the RSBI. It's also less reliable in, for example, women who naturally have smaller lungs and tidal volumes.
And how do we actually measure it? Can I just look at the numbers on the ventilator screen?
No, and that is a very common student mistake. You must measure the RSBI while the patient is breathing completely spontaneously. That usually means disconnecting them and putting them on a T-piece for 1 to 2 minutes. You cannot measure it while the machine is giving them any support at all. It has to be their unaided effort.
Got it. Has to be a true reflection of their own breathing pattern. Okay, so let's say our patient has passed the screen. We've measured their RSBI, and it's 60. They look good. It's time to actually try a formal trial. This brings us to a huge section, methods of weaning.
This is a very high-yield section for your long answer question. Historically, we did all sorts of complicated things, but over the last 20 years, the evidence has really converged on one gold standard approach.
And that is?
The SBT, the spontaneous breathing trial.
What exactly is an SBT? How is it different from just measuring the RSBI?
It's a formal stress test, a dress rehearsal for extubation. We're effectively saying to the patient, okay, we're going to take away most or all of the support for a set period of time. Let's see if your respiratory system can handle the load. It's an endurance test, not just a 1-minute snapshot.
How long does this audition last? The textbooks seem to vary quite a bit on this.
The classic answer is 30 to 120 minutes, but here's the modern evidence-based answer for your Viva. 30 minutes is almost always sufficient.
Really? Not 2 hours?
No. Multiple large trials have shown that if a patient can pass a 30-minute SBT, they are just as likely to be successfully extubated as a patient who endures it for 2 hours. Dragging it out to 120 minutes often just needlessly fatigues the patient without adding any real predictive value.
Okay, 30 minutes is the key. Now, there seem to be two main ways to conduct this SDT. The old-school T-piece versus low-level pressure support. Walk us through that battle.
The T-piece trial is the Spartan method. You physically disconnect the patient from the ventilator circuit and attach them to a T-shaped tube that delivers humidified oxygen. The patient does 100% of the work of breathing.
Sink or swim, basically.
Exactly. The main advantage, its pro, is that it's a true, unadulterated test of their strength. The con list is much longer. It can be brutal. There are no ventilator alarms if they become apneic. And, most importantly, breathing through that narrow endotracheal tube adds a significant amount of resistance that won't be there once they're extubated. So it's arguably an unfairly difficult test.
It overestimates the work they'll have to do after extubation.
Precisely. Which leads us to the kinder and now more common alternative.
Which is pressure support ventilation, or PSV.
Yes. In this method, you keep the patient connected to the ventilator. You set the mandatory rate to 0, so they have to initiate every breath, but you provide a small amount of pressure assist with each breath they take, usually around 5 to 7 centimeters of water.
Why that specific number, 5 to 7?
Because research has shown that's just enough pressure to overcome the artificial resistance of the endotracheal tube. It essentially cancels out the breathing through a straw effect. It's designed to mimic what it truly feels like to breathe naturally without a tube in place. This is the preferred method in most modern ICUs.
Okay, so PSV is generally preferred. Now, I have to ask about SMV, synchronized intermittent mandatory ventilation. It's in all the older textbooks as a weaning mode.
And here's an official expert warning for your exam. If you are asked about weaning with SMV, you must be very critical of it. Do not recommend SMV as a primary weaning mode in a modern context.
Why not? The logic of slowly turning down the number of machine breaths per day sounds, well, logical?
It sounds logical on paper, but physiologically it's a disaster. It has been proven to be the slowest weaning method. Think about it. In between the mandatory machine breaths, the patient is left to breathe spontaneously through a high-resistance ventilator circuit with absolutely no help. They get exhausted.
So it actually prolongs ventilation.
Significantly. The data is overwhelmingly clear. Daily spontaneous breathing trials get patients off the ventilator faster than gradual weaning with SIMV. So, for your exam, SIMV is a historical method that has been superseded by the SB2 approach.
SIMV is out. SBT is in. Good to know. So during this 30-minute SBT, what does failure look like? When do I need to hit the abort button and put them back on full support?
You're looking for objective signs of distress. You abort the trial if the patient becomes agitated or diaphoretic, sweaty and clammy.
Okay.
You also abort for numerical changes. If their respiratory rate climbs above 35 per minute, if their oxygen saturation, the SpO2, drops it below 90%, or if their heart goes crazy, a heart rate above 140, or a sustained change of more than 20% from their baseline.
And if they fail, we just stop.
You stop. You immediately put them back on their previous full support settings. You let them rest. And this is key. You figure out why they failed and you try to fix it. Then you try again tomorrow. You don't push them through failure. Weaning is very often a process of 1 step back, 2 steps forward.
Try again tomorrow. Got it. But let's be optimistic. Let's say they pass. You breeze through the 30-minute SBT. They look great. Are we now ready to pull the tube?
And this leads us to the most critical conceptual hurdle of the entire topic. This is Section 6, Extubation criteria.
Right.
This is the moment where I, as the senior faculty in your Vivo, would lean forward and say, excellent, the lungs are working, the weaning trial was a success, but tell me, is the pipe ready to come out?
Because we're back to that fundamental distinction. Weaning is done. Extubation is a separate decision. So what's on this new checklist?
For extubation readiness, you need to assess 3 broad categories: airway patency, airway protection, and secretion load.
Let's start with patency. This is all about swelling, isn't it? Laryngeal edema.
It is. The tube has been irritating the larynx for days. Is the airway swollen shut around it? The way we check for this is with the cuff leak test.
Okay, walk me through the mechanics of the cuff leak test.
The endotracheal tube has an inflatable balloon, the cuff, that seals the trachea to prevent leaks. To do the test, you first thoroughly suction the mouth and throat. Then you completely deflate that cuff.
Okay.
Normally, because the tube itself is smaller than the trachea, when the ventilator delivers the next breath, Some air should be able to leak out around the outside of the deflated tube and exit through the mouth. You can often hear it.
So a leak is actually a good sign.
A leak is an excellent sign. It means there's space. It means the airway is patent. If there is no audible leak, or if you measure the volumes and the leak is very small, say less than 110 millowell or less than about 25% of the tidal volume, that's a big red flag.
And it suggests
that the laryngeal tissues are swollen so tightly against the tube that there's no room for air to pass. If you pull that tube out now, the airway might close off completely. Stridor, respiratory arrest, a disaster.
So there's no leak, the tube absolutely stays in.
Usually, yes. The plan then would be to consider giving systemic steroids, like dexamethasone, wait 12 to 24 hours for the swelling to go down, and then test again. This is a very common exam scenario. No cuff leak. What is your management plan? The answer is steroids and wait.
Okay, that's patency. Now what about protection? This is about the cough and gag reflexes, right?
It's mostly about the cough. The gag reflex is less important. You need a strong, effective cough to be able to clear your own mucus and saliva. If they can't cough, they will aspirate and develop pneumonia within hours of extubation.
Can we measure that objectively?
We can. You can measure the cough peak expiratory flow. If it's less than about 60 liters per minute, their cough is too weak. They are at high risk.
Which brings us directly to the third point, secretions.
Yes,
Yeah.
It's a simple volume game. If you're having to suction the patient every 15 minutes to keep their airway clear, do not extubate them. They won't be able to keep up. You're looking for a patient who requires suctioning infrequently, say less than every 2 to 3 hours.
And what about the brain's role in all this?
The final check is neurological status. They need to be awake and cooperative enough to protect their own airway. Generally, that means they can follow simple commands. Open your eyes, stick out your tongue, squeeze my hand. We usually want a GCS of at least 8, but realistically, you want them to be more alert than that. A comatose patient cannot protect their airway from aspiration, even with a strong cough reflex.
So to summarize that safety net, a successful SBT means the lungs are ready. But for the tube itself to come out, you need 4 more things: a present cuff leak, a strong cough, a low volume of secretions, and an awake brain.
That is a perfect summary. That is what separates the pass from the fail.
All right, the full checklist is complete. Our patient is a go. We're proceeding. Section 7, the extubation procedure itself. This seems simple on the surface. Just pull the tube out, but I suspect there's a proper short note answer hidden in the details.
It's a formal procedure, not just a yank. You have to be methodical to make it safe. Step 1 is preparation. Sit the patient up as much as possible, at least 45 degrees. Get your oxygen mask ready to go. And most importantly, have your re-intubation kit laryngoscope, tubes, drugs open and right next to you just in case.
Be prepared for failure.
Always. Step 2 is suction, and this is vital. You must suction the oropharynx, the mouth, and the area above the cuff thoroughly before you deflate it.
Why is suctioning above the cuff so incredibly important?
Because for days or even weeks, a disgusting pool of bacteria-laden secretions has been sitting on top of that inflated cuff. It's a cesspool. If you just deflate the cuff without suctioning first, gravity takes over, all of that gunk slides straight down into the lungs.
You cause an immediate aspiration pneumonia.
You do. It's a classic iatrogenic complication. So suction above the cuff first, then suction down the tube. Then step 3 is oxygenation. Pre-oxygenate with 100% oxygen for a few minutes.
Okay, we're ready for the main event, the maneuver itself.
Deflate the cuff completely. Ask the patient to take a big, deep breath in. And here is the pro tip. You remove the tube smoothly at peak inspiration.
Peak inspiration, why then?
Think about the physics. If you pull the tube out when the patient's lungs are full of air, the very next physiological event will be an exhalation, or even better, a cough. This creates a blast of positive pressure that blows any remaining secretions out of the airway, away from the trachea.
Whereas if you pulled it out during expiration,
Their very next move is to inhale. They would just suck everything down. It's a small detail that makes a huge difference to safety.
that is a brilliant practical tip. Pull at peak inspiration, then you immediately put the oxygen mask on them.
Exactly. A face mask with cool, humidified oxygen. You encourage them to cough. And then you do not walk away. You enter the danger zone.
Section 8, post-extubation care and failure. How long is this danger zone? How long do we need to watch them like a hawk?
The first 2 hours are the most critical window. That's when most failures will declare themselves. You are listening for stridor, that high-pitched whistling sound of airway swelling. You are watching for signs of respiratory distress, fast breathing, use of neck muscles. And you are watching for somnolence, for them getting sleepy, which could mean their CO2 is rising.
How do we formally define extubation failure for an exam? What's the time window?
The standard definition is the need for re-intubation within 24 to 72 hours of extubation. For exams, 48 hours is a very safe number to quote, and it happens in about 10 to 20% of ICU patients.
What are the main causes? Why do they fail?
For your answer, you should categorize the causes. 1. Airway problems. This is laryngeal edema causing obstruction or laryngospasm. 2. Respiratory problems. This is simple muscle fatigue, retained secretions they can't cough up, or aspiration.
Okay, and the third category?
3. Cardiac problems. And this is the most fascinating and often missed one-flash pulmonary edema.
Wait, explain that. How does taking a breathing tube out cause acute heart failure? That feels completely counterintuitive.
It's beautiful but dangerous physiology. Positive pressure ventilation. The machine pushing air in actually helps a failing heart. It acts like a crutch. The positive pressure in the chest squeezes the great veins, which reduces the amount of blood returning to the heart. That's decreased preload.
Okay.
It also reduces the pressure the left ventricle has to pump against. That's decreased afterload. So the ventilator is effectively making the heart's job easier.
I see. It's supporting the circulation as well as the breathing.
Exactly. Now, when you extubate them, you suddenly switch from positive pressure breathing to negative pressure spontaneous breathing. The floodgates open, venous return shoots up a huge increase in preload, and the afterload increases. A weak, borderline compensated left ventricle can be completely overwhelmed in an instant. The lungs fill with fluid.
So the patient fails not because of their lungs, but because their heart couldn't handle the transition.
Precisely. It's a classic cause of failure in elderly patients or those with known cardiac disease.
And if failure happens, whatever the cause, what's the management principle?
Do not delay reintubation. This is a critical safety point. Mortality rates skyrocket if you wait and see how they go. If they are failing, they are failing. Intervene early. The one major exception to this is in COPD patients.
Right, which leads us nicely to the special situations. COPD patients change all the rules, don't they?
They do. With a COPD patient, you often cannot wait for perfect blood gases before you extubate. They are chronic CO2 retainers. Their baseline CO2 is high. If you wait for it to normalize, they will be on the ventilator for the rest of their lives.
So we have to lower our standards, in a way.
We shift the goalposts. For many COPD patients, the best strategy is to extubate them directly onto non-invasive ventilation, or NIV, like a BiPAP machine. We accept a slightly high CO2 as long as their pH is acceptable and they're comfortable. It's called a facilitated extubation.
Okay, what about the other end of the spectrum? The neurological patients, like a severe head injury.
They are the opposite problem. They often have young, strong, healthy lungs but a damaged brain. They can breathe perfectly well, but they can't protect their airway.
So they'll pass the SBT every single day, but they will always fail the extubation criteria because their GCS is too low.
Repeatedly. In these patients, you have to stop pretending they're going to magically wake up tomorrow. The correct plan is to move towards an early tracheostomy, usually around day 7 to 10 of ventilation. It bypasses the airway protection problem, makes suctioning easy, and gets them off the ventilator much faster.
Makes sense. And one last special case, the patient who was a known difficult airway, the one who was a nightmare to intubate in the first place.
You must be extremely cautious. If you pull that tube and their airway swells up, you might not be able to get another tube back in. For these high-risk patients, we often use something called an airway exchange catheter.
And what's that?
It's a long, thin, hollow tube. Just before you pull the endotracheal tube out, you slide this catheter down inside it. You then remove the ETT over the catheter, leaving the catheter in place, sitting in the trachea.
It's like a placeholder.
It's an insurance policy. If the patient fails and you need to reintubate, you can just thread a new ETT back over the catheter as a guide. It can be a life-saving maneuver.
Okay, we are nearing the end of our structured review. Let's cover some common exam questions and Viva traps. You already mentioned the RSBI trap, but let's reinforce it one more time.
The examiner will look at you and say, the patient's RSBI is 90. That's a passing score. Should you extubate?
And the eager but wrong student says yes.
And that student fails. The safe answer is, an RSBI below 105 is a good predictor of weaning success. However, it tells me nothing about the safety of the airway. I must also perform a full extubation assessment, checking for a cuff leak, a strong cough, and an adequate GCS before I can consider removing the tube.
It all comes back to that core distinction. Here's another one. What's the difference between a T-piece trial and a PSV trial?
The trap answer is just describing the equipment. The good answer explains the physiology. A T-piece trial can overestimate the work of breathing because the patient must overcome the resistance of the ETT. A low-level PSV trial is designed to compensate for that artificial resistance, providing a more accurate simulation of post-extubation breathing. PSV is generally considered a more physiological test.
Got it. Any other common traps?
How long should the SBT be? The safe answer. While trials can last up to 2 hours, recent evidence suggests that 30 minutes is usually adequate to predict success. Prolonging the trial may not add predictive value and can cause unnecessary patient fatigue. If you just say 2 hours, you sound like you haven't read a paper since 2005.
Okay, presentation. We're writing this 20-mark answer out. What visuals do we need to include?
You absolutely must draw a simple weaning protocol flowchart. It shows the examiner that you think in a structured, algorithmic way. Box 1, daily screen. Arrow down, pass, yes. Box 2, perform SBT, arrow down, pass, yes. Box 3, assess extubation criteria, cough, leak, GCS, arrow down, pass, yes. Box 4, extubate.
Simple, logical flow.
And on the side of the page, draw a box for the RSBI. Write the formula clearly, FVPL. Write the cutoff, 105. Visuals break up the text and score easy marks.
Excellent. We have covered a huge amount of ground here, from the physiology of the load capacity balance all the way to the physics of the cuff leak test. Let's wrap up with the final summary. Give us the high-yield bullet points for our final revision sheet.
All right, here is your take-home list, the absolute essentials for your answer sheet.
Weaning is a process. Extubation is an event. Never, ever confuse them.
Always treat the underlying cause of respiratory failure first.
Use a daily screening protocol to identify candidates for weaning early.
The spontaneous breathing trial is the gold standard method. 30 minutes is usually enough.
The RSBI, with a cutoff of less than 105, is the best single predictor of weaning success.
Extubation requires a completely separate assessment. Airway patency, cuff leak, protection, cough, and mentation, GCS.
Post-extubation vigilance, especially in the first 2 hours, is critical.
If extubation failure occurs, do not delay reintubation. Mortality is high with delay.
Be aware of cardiac causes of weaning failure, especially flash pulmonary edema after the removal of positive pressure.
That is incredibly comprehensive, thank you. Before we close this out, can you give us one final thought, something that goes beyond the numbers and protocols?
We've talked a lot about the science, about the indices, the blood gases, the pressures. But I want you to remember that weaning is also intensely psychological. A patient who is terrified, anxious, or delirious will fail an SBT, even if their lungs are perfect physiological specimens.
The human factor.
The human factor. When you're standing at that bedside, you have to treat the fear, not just the ventilator screen. Talk to your patient. Explain what you're doing. Reassure them. Sometimes, just holding a patient's hand and coaching them through their breath is more effective than any pressure support setting you can dial in. That connection, that humane care, is often the final piece of the puzzle that separates success from failure.
Treat the patient, not just the numbers. That's a perfect note to end on. Thank you so much, senior faculty, for guiding us through this absolute minefield. I honestly feel much more prepared to tackle that 20-mark question now.
Good. Write it in points, draw the flowchart, nail the definitions, and good luck with the exam.
And to all of you listening, you've got this. Good luck with your studies, and thanks for joining us on the deep dive.